All right, we are recording. Well, hello, Fertility Rally family. We are coming to you from many different places. Dallas, Texas for me, up in New Jersey, New Orleans, North Carolina, all different places today. And we are hosting a Med Ask Me Anything today. My name is Abby Mercado. I'm the CEO of Best Shot. We're a patient's companion in fertility treatments. And I'm also a former fertility patient myself. So we're going to go around and introduce ourselves. And we're going to start with Dr. Huber. So tell us a little bit about yourself, what you do and where you do it and why you became what you became.
Yeah, absolutely. Well, thank you so much for having me, Abby. It's a pleasure to be here. So my name is Jay Huber. I'm one of the fertility specialists at the Fertility Institute of New Orleans. Yes, I'm in North Carolina currently, but I'm housed in New Orleans, in the New Orleans area. I became a fertility specialist because I very quickly learned, I did an MD PhD, so I'm a physician scientist, and I really appreciated the direct correlation between bedside to bench. I don't think that there's a field of medicine that you can actually see that relationship any closer than in the world of fertility medicine. That drive to become an infertility specialist was sealed when I did my OBGYN rotation in medical school. And at the end of the day, I loved women's health. I loved to move the field forward. I loved studying the things involved in women's health. And I wanted to be a student of the game for the rest of my life. I always joke that fertility medicine is a hobby that I happen to get paid for. So I go to work every day and I really enjoy what I do. It makes my heart smile. So.
Wonderful. All right. Well, I'm going to pick on Wendi next. Wendi, tell us about yourself.
I am Wendi. I started working at the Fertility Institute of New Orleans 22 years ago, almost 23, and kind of fell into this just looking for another job. I did pediatrics first and fell into this field and absolutely love it, and became the nurse manager back in May and just love what we do. I love dealing with the patients. I love just the interaction with them, even the ups and the downs, to help them through this horrible, horrible journey to hopefully come out on the other side with something wonderful for them.
Awesome. Thanks for that. And then last, but certainly not least, Vicky, please tell us about yourself.
Hi, thank you for having me. I'm a fertility pharmacist. I've been doing this since I graduated. I found the original Schrafts pharmacy just by driving by. They were in my neighborhood. I walked in, asked them if they needed a new pharmacist. They took a chance and taught me everything I needed to know about fertility. I fell in love with the field. I fell in love with the patients and how we are able to help them and guide them through the journey. We found that obviously self-administration of medications is very difficult for patients who've some of them never even seen a needle and have to do it themselves. It's very scary. So I felt very privileged to help, and I feel continue to help the patients. And for more personally, I struggle with infertility myself. So I do have an IVF baby. So I have what they call secondary infertility. I had 2 children, and then we wanted to have a third one, and we couldn't get pregnant. So, and it even made me closer to our patients. We do open the box calls, counseling calls. I cry with them because I relate, So this is the most rewarding job I could ever hope for, and I would continue to thrive and grow in this business. Clinically and together, with the patient. So thank you so much for having me. I look forward to this meeting.
Yeah, cool. Well, thank you all. Fascinating backgrounds, and you're clearly all in it for the patient. That's the thing that has kind of drawn everyone here together. So we have 9 questions today, and we're going to go around. These questions are from the Fertility Rally community, and I'm going to go around and ask each person a couple questions. And so these questions are, more or less designed for them individually. So I will go ahead and get started with question number 1. Okay, so this question will be for Dr. Huber. So if the goal is to get as many eggs as possible, why do REIs have so many medication protocols? What is the difference between them? Do all REIs use the same protocols? Why or why not? Dr. Huber, take it away.
Great start. So, yeah, I would say even as an REI physician, the number of protocols that we have are daunting. If you ask my nursing staff, I keep them. I keep a protocol book, and I frequently go and refer to it because it's so much information. Things are always changing that I want to make sure that I do it correctly every time. Kind of from the 30,000 foot view, what patients should realize is that every patient is different. Right? We do IVF cycles for a number of different indications. So for instance, if the highways between the ovaries and the uterus, being the fallopian tubes, are blocked, that's one indication. We do IVF for male factor infertility, where there's not enough sperm to get patients pregnant the traditional way or with an intrauterine insemination. We do IVF to do genetic studies on the embryo. We also do IVF for individuals with diminished ovarian reserve, right? So we're trying to smash as many menstrual cycles into one to try and get the highest number of eggs. And the way that we do that is to utilize different protocols. And in general, those protocols can be broken down into really just kind of 3 areas. The first one is the stimulation, right? And anyone who's gone through an IVF cycle has typically heard of the term FSH or follistim. And I have no financial relationships to any of these companies. I don't endorse one versus the other, but something like follistim or gonal F. Those are the medications. Those are the stimulation medications. Those are the ones that are going to tell the ovary you need to start making eggs. The other thing that we need to do is block ovulation. So that's the second phase, right? So there's stimulation and then ovulation blockade. And we do that by either using something called Lupron from the very beginning, or we use an antagonist like ganirelix or cetrotide. Those are the medications that will block the discussion between the brain and the ovary, and it will block ovulation before we are ready. The third phase is the trigger, right? So the trigger is what will tell those eggs that have been listening to the FSH throughout the process to go ahead and start to become mature. Right. And once those eggs are mature, that's when we go and do the retrieval. The reason why I want to bring up those 3 different phases is because the protocols are all based around impacting those phases a little bit differently. And the reason why we need to do that is because with each indication of why we're doing IVF, we need to be able to impact the discussion between the brain and the ovary a little bit differently with each protocol. Sometimes we need to have a little bit more of that discussion up front between the brain and the ovary. Sometimes we need to have it on the back end, or sometimes we can just have it almost like a natural cycle and ultimately get a good cohort of eggs. So it really depends on the reason why we're doing the IVF cycle. And then it also really depends on how did you do on a first cycle? Sometimes patients just respond better to this protocol versus another protocol. And there's really not much that you could have done to guess which one a patient would do better on. So a lot of that is just experience and tweaking those protocols. But in general, we use so many protocols because of these so many indications, the variety of ages in the IVF world. But that's kind of the reason why we have all those protocols. I think what the second portion of that question was, do you mind repeating that, the last portion?
Yeah. So why do doctors all have the same protocols, and
Great.
Why or why not?
Great. I think in general, the answer to that is yes. You can break this down into 3 or 4 large classifications of protocols, and that really is based on the stimulation and the blockade of ovulation. But many times we will tweak just these little additives, or we'll add a certain medication in a little bit earlier, or change the dosing. And that's very much a personal preference. So there is a little bit of academic and medical liberty that we take in what we see in the pre-IVF workup, and to kind of hedge which protocol we think a patient will do the best on.
Yeah. Awesome. Well, thanks for breaking that down for us, Dr. Huber. That makes a lot more sense than it did before. So, all right. This question, randomly selected, is for Vicky. So, Vicky, which common fertility medications need to be refrigerated, and why? What if I forget to refrigerate a med that needs to be refrigerated? Can I still take it?
So there are most of them, well, not most of them. So the gonadotropin, so the follicle stimulating hormones, follistim, gonal-F, usually need to be refrigerated. There are some trigger shots that need to be refrigerated, like Avadril. And there are 2 medications that are used to block ovulation. Those are ganirelix. Well, the 2 antagonists are ganirelix and cetrotide. Ganirelix actually cannot be refrigerated. The cetrotide has to be refrigerated. So it's just the way the companies make the products, how they test them, how the compound, how the chemical, based on the chemical stability. But the good news is that even if you forget to refrigerate the medication, it is actually good for so the follistim and gonal-F are good for 30 days at room temperature. So they don't need to get very nervous. Patients don't need to get nervous about that. They can keep them at room temperature for 30 days. Actually, 90 days if unopened, once punctured, 30 days. And the Avadril is good for 30 days at room temperature. So if they don't refrigerate it, they can still use it. And then cetrotide is actually good for 7 days at room temperature. So usually these chemicals are still stable at room temperature. So it's not like you took it out of the refrigerator and an hour later these medications are no good. The companies understand, and they make them stable. If you keep on the refrigerator, it's going to extend that shelf life all the way to the expiration date on the box. So that's the reason why. It just really depends on how companies, the chemical itself, and whether it needs to be refrigerated or not, but they're not that fragile that you can't keep them at room temperature.
Got it. Yeah, that's actually super confusing with ganirelix and cetrotide, because they're kind of the same thing, right?
They are the same thing.
Okay.
Ganirelix can crystallize in the refrigerator, meaning it will form, it'll get cloudy. But again, it's not that fragile. So if you put it in the refrigerator, if you take it out of the refrigerator and it's still clear liquid, they can go ahead and use it. It's just again, just the way the company made it. It should be kept at room temperature.
Yeah, got it.
So COVID vaccine. Sounds like we're talking about COVID vaccines. One has to be refrigerated.
Yeah, and one has to be, it's that crazy freeze. The one that Pfizer made, it has to be frozen. The other one refrigerated. Yeah, it's just, I think it's just a little, how they brand it. I don't know.
Who even knows? Oh my goodness. Well, hopefully you guys have Vicky as your pharmacist, because she'll make you feel a lot more relaxed.
Thank you.
So, all right, cool. So this next question is for Wendi. Okay. So I missed a dose of Menopur, follistim, or gonal-F. Now what? What do I do? Is my cycle canceled? Like, what happens?
This happens a lot. The patients will always call us the next day or call a doctor overnight, panicking that they missed their dose. It's okay if you miss a dose of medication. It's not going to hurt you in any way. But of course, I tell everybody, if you need to remember the medication, you can set an alarm on your phone. Make sure you have your calendar available to you all the time. And always make sure to let your coordinator or your physician know that you missed a dose. They may have to adjust the next dose to catch up, Or at least if you come in the next day and they say, okay, not a whole lot happened, you need to let them know I missed the dose. So I say just always don't panic about it. Go back in the next day or call the next day and let them know. But it's okay if you miss one dose of your medicine, if it's a stimulation medicine. If you are on a medication like Lupron or Ganirelix, and you miss the medication and you're in IVF cycle, you could really mess up your whole cycle. So set the alarm on your phone, make sure you have some kind of reminder to remind you.
Use the Best Shot app. Ask your doctor for the Best Shot app.
Yes. But make sure that you have it so that you don't miss those types of medications. It's real important that we don't skip those medications.
Yeah. Okay. That makes a lot of sense. So let me get this straight. So if Dr. Huber is my physician, I should call him at 3 a.m. if I miss
Absolutely.
a dose. Absolutely. Okay, cool. All right. Thank you for breaking that down for us, Wendi.
I welcome all calls. No question is a stupid question.
We are also on call. Schrafts Pharmacy, like all the pharmacists are always on call 24/7. We get those calls as well.
Oh man,
yeah.
That's crazy. I will admit I did it. Like I missed it. It's hard, and that's why we're doing this Med Ask Me Anything, because it is hard. All right, this next question is for Dr. Huber. So what is OHSS, or ovarian hyperstimulation syndrome, and how will I know if I have it? How often do patients get it, and how is it treated?
Yeah, so even bringing up OHSS makes me kind of cringe. It's one of those dreaded consequences of ovarian stimulation, right? So the whole process of IVF is called controlled ovarian hyperstimulation. The goal of an IVF cycle is to stimulate the ovaries, overstimulate the ovaries to do more than it typically would. So in a normal menstrual cycle, you make one egg. What we're doing is we're taking control of the brain to tell the ovary, you need to make more than one egg. We're trying to make as many eggs as possible. And during an IVF cycle, the reason why docs will monitor you so much and will adjust your medications is for two things. Number one is to try and optimize the oocyte yield or the egg yield. But number two is to keep you safe. And I would actually argue that those are the other way around. Number one, to keep you safe. Number two, to optimize our yield. But the ultimate goals, those two things, sometimes the cycle takes off a little bit. And even with those medication adjustments, patients are at risk of having the situation of ovarian hyperstimulation syndrome. Now that syndrome is a spectrum, right? So there's kind of four phases to that syndrome. There's mild, moderate, severe, and critical. And I would argue that at least half of our patients have at a minimum the mild OHSS, because you have to realize we are asking the ovaries to do a supra-physiological job and make more than one egg and make multiple eggs. So at a minimum, patients will feel some bloating, a little bit of abdominal pressure, some pelvic pressure, maybe a little bit of nausea, and a little bit of lethargy, just kind of run down and, oh my gosh, I feel like I have grapefruits in my belly, which is probable. And then that second phase is, when patients are starting to have more nausea, vomiting, not really tolerating oral liquids and food. Pain is out of proportion to what you would expect. That's where you hit that moderate. And then to jump up to that severe, there are certain objective criteria that we use, and we look at blood work, and we also look at ultrasounds to really put you into a classification of OHSS. Now, the critical is the most severe, and luckily that has almost gone away with the advent of various trigger medications, and we'll get into that in just a second. But the critical stage is where you would need IV fluids, some blood thinners like Lovenox or shots, those types of things. The way that you'll know if you have it is by staying in constant communication with your doc and your IVF coordinators and nurses. We educate our patients pretty aggressively in this regard, because number one, we want you to feel comfortable. Number two, we want you to be safe and know what are the common symptoms to look for. So it's that the things that I would expect out of an IVF cycle with a little bit of mild OHSS are things like abdominal distension, some heavy pelvic feelings, bloating, those types of things. But as those symptoms, we check in with our patients pretty frequently, and as those symptoms evolve, that's when the clinic will start to take the necessary steps to continue to watch. Now, honestly, the treatment for OHSS, the mild and moderate, is really just conservative therapy, comfort measures, increasing your oral intake, salty foods, anti-nausea medications, pain medications, rest, monitoring urine output, monitoring weight, those types of things. Once you get into the severe and the critical, that's where it becomes a little bit more aggressive therapy, like IV fluids, maybe even paracentesis, where we put a needle into the belly and take some of the fluid out, those types of therapies. The best treatment, though, is prevention.
Yeah.
And we do that by trying to reduce your overall risk, number one. The second way is by manipulating the trigger medications, using a Lupron trigger over an HCG trigger. And then the third is a freeze-only cycle, where we freeze embryos instead of doing a fresh transfer.
So beyond mild, this isn't super common, right?
I'm sorry, say that again.
Beyond like a common case, this isn't like, or a mild case, this isn't super common, right? Like what percentage of patients would you say actually this happen to?
Good question. So I counsel all of my patients as if they're going to have mild, right? You're going to feel some discomfort, and the symptoms after an oocyte retrieval. Remember, we're going through the vaginal wall with a needle into the ovary. So you're going to feel some discomfort just basically from the oocyte retrieval. So those symptoms kind of can go hand in hand. But in general, I counsel everyone as if they're going to have mild OHSS. Anyone with a higher estradiol level or who got a little bit of an HCG trigger, I then counsel them for the features to look for with moderate. And I would say less than 10% to 15% now, with the advent of the Lupron trigger, are even going to be in that moderate OHSS. Severe and critical, those are situations that we should not be putting our patients into. So I would argue that less than 3 to 5% of the time are you really having the discussion of a severe to critical OHSS.
Yeah. Okay. Whew. It's good to know. All right. So this, thanks for that, Dr. Huber. That was a great explanation. So this next question is for Wendi. So Wendi, if I get an injection site rash, does it mean that I'm allergic to that medication and shouldn't take it?
No, not necessarily. Some of the medications will cause a little redness in the area where you give them, but it does not mean you're allergic to the medication. If you are taking, the only medication I would say that you need to kind of really watch for and be worried about is if you're taking a progesterone and oil injection. Some of the patients can be allergic to the oil that the progesterone is in, sesame oil or one of those. If you have that kind of reaction, of course, let us know of any reaction you have, but don't panic about that, because it's common to have a little site reaction on the regular medications. If the site gets worse, of course, let us know, let a nurse look at it, and maybe sometimes we'll put like some warm packs on it if it's like swollen or anything. But for the most part, the medications and the site reactions are not an allergic reaction. It's just from taking the medication, you can have like a little mark on your skin. If it gets worse, draw a line around it and make sure it's not spreading. But for the most part, they can take anything. I haven't ever had anybody that was truly allergic to Follistim, Gonalef, or any of the stimulation drugs.
Yeah. Okay, that makes sense. So can progesterone and oil, and it's usually a good sign you're taking progesterone and oil, right? So yay, patients. can it be mixed with something other than sesame oil? Like,
Yes.
how does that work? Okay.
Vicky could answer that more than I could, but
Yeah,
yes,
Vicky. Yeah. Okay.
I actually had a patient this week that was on progesterone and oil and sesame oil. And as she continued to take it, continued to have more and more of a reaction to the point that she was done, did not want to take it anymore. We offered her progesterone in olive oil, but she was just done with the injection. So we just switched her over to endometrin, which is a vaginal preparation to help. But yeah, there is an alternative, but they just have to let us know that they're having the reaction.
Right. That's actually a really good tip to draw a line around it. I hadn't thought of that, but that's a very easy way to make sure your rash isn't spreading.
Yes.
So that's good. Okay, awesome. Thanks for that, Wendi. All right. So this next question is for Vicky. So there's some big words in this sentence. I hope I can pronounce them. What's the difference between a biologic gonadotropin, like Menopur, and a synthetic gonadotropin, like Follistim or Gonal-f? What's the difference?
So Menopur.
And what's a gonadotropin, and why is it called that? And like, can you call it something else? And yeah.
So your
gonad, I don't even know.
Are your stimulation medications? So your Menopur, Follistim, Gonal-f. Those are really the three main players. You know, back in the day, I'm sure Dr. Huber knows Pergonal, Repronex, Brevell, all those drugs. So the first gonadotropin, so the follicle stimulating hormones, were urinary products. And the first one, one of the first ones was Pergonal. And funny story that it was actually made out of female urine, well, extracted from female urine that came from nuns in Italy. So it's actually a very interesting story. And what they were able to do, so they found the women who are menopausal women produced the most amount of this FSH and LH hormone. So they would purify that from the urine and make a drug out of it. Menopur today is right now that's available in the United States, the only one that's urinary product that's available. And the difference is that it has both of the hormones in it. So it has the follicle stimulating hormone in it and luteinizing hormone in it, which are the two hormones responsible for stimulating follicles. And later, I believe in the 90s, they came out with synthetic products like Follistim and Gonal-f, and those were produced through recombinant DNA technology. So and I wouldn't say that, you know, one is better than the other. It's both, you know, obviously synthetic is pure, urinary product is purified. The difference is that the Follistim and Gonal-f only contain follicle stimulating hormones, so FSH only. Menopur has both FSH and LH. So sometimes a lot of times in the IVF cycle, you'll see the combination, the drugs that are ordered for the IVF cycle. You have the Menopur and one of the FSH products like Follistim and Gonal-f, or Gonal-f, and the doctors will order both just so the patient can have the LH and the FSH to stimulate with. To how the combinations and how they do it and why they do it, I think Dr. Huber could probably answer that question better. But that's the main difference between the two. Yeah.
Okay, wow. I just learned so much, and I work in this business, so that's really fast. So, okay, I could ask like 5 million follow-up questions, but I'll probably just go on to the next question because that was an excellent explanation of the question that I asked. So thank you, Vicky. That was fascinating. Okay, so this is a question for Wendi. Okay, so I want to ask about 6 different things that I can or cannot do during the process of taking my stim meds. And I would love for you to tell me if I can do them or if I cannot do them. So can I drink alcohol? Why or why not?
Well, you want to treat your body as if it's already pregnant. And we all know that alcohol is contraindicated in pregnancy. But if I tell every one of my patients you cannot drink alcohol through this process, we may not have a lot of patients left. So
you're saying it's hard. I don't know.
Yeah. And so, really early in their cycle, if they are not to ovulation yet, yes, drinking alcohol in moderation is fine. Don't get drunk every night, but having a glass of wine here and there is not going to be a problem, and it's not going to hurt you.
Okay. Cool. Can I have caffeine?
Yes. Because if I didn't give you caffeine, we would not be really nice to each other. I think 1 to 2 cups of caffeine a day is not going to hurt anybody through their stimulation. It's going to be fine. It's not going to hurt you. And again, you're treating your body as if it's pregnant. So I think once you get past ovulation, yes, you can do it. But once you find out you're pregnant, yeah, you want to kind of limit it and start backing off.
Okay. Whew. I love caffeine. Have intercourse.
Yes, that is another, yes, you can have that. But as you get closer to ovulation, follow your clinic's guidelines as to how long to abstain before ovulation. You don't want to have relations every night. And probably 3 to 5 days before ovulation, you want to hold off to make sure that we have good, fresh sperm by the time we have either insemination or IVF or whatever you're having done.
Okay, cool. Good tip. Exercise.
Exercise is fine as well in moderation. If you are a marathon runner and you have already gone through your stimulation drugs, I don't want you going out running. I don't want you putting pressure on the ovaries. We don't want any of that. Another thing to remember is as you're exercising, you're shunting blood away from the ovaries, away from the uterus to the muscles in the arms and the legs. So keep it in moderation, but yes, you can continue to exercise, and we want our patients in shape. So we want you to continue.
Yeah. Okay. Travel.
Traveling is fine as well. Follow your clinic's protocols as far as travel. If you are traveling, things to remember: if you're on injectable medication, you will need to bring your medication on the plane with you. So you will need a letter from your physician to bring needles onto the plane. Second thing to remember is if you're going to travel and you're beginning a stimulation cycle, let your coordinator know, because you may not realize how often you'll need to be into the clinic to be monitored. And if you're traveling, you can't be in the clinic. So they may have to alter a few things. So of course, let the clinic know when you're traveling, when you'll be back. They may have to alter start dates or, return dates.
Oh, travel is so stressful during a stim cycle. Also, wear a mask when you travel.
You shouldn't be traveling right now anyway, but
yeah.
Right.
And last, but most certainly not least, because this is one of my favorite winter activities, use the hot tub.
You may use a hot tub, but no, you may use the hot tub, but your partner may not use the hot tub. Because the heat is not good for the sperm. I need fresh sperm for the stimulation cycle. And if he has been using the hot tub, it can affect the sperm out to like 4 to 6 months later.
What?
So you
That's
have
crazy.
You have to keep that in mind, because the sperm do not like heat. We live in the South, and some of our husbands are chefs in restaurants and in the New Orleans area. I need to know that it's hot in the kitchen. So we do have to monitor their sperm, make sure that the sperm is good, because they're working in the heat all the time.
Oh, that makes me really hungry for breakfast.
Hot tubs are fine for the patient, but not so much for the partner.
Yeah, that makes me, I feel like I should have a beignet or something for breakfast after talking to a couple people from New Orleans. That's really funny. And that makes me want to move to New Orleans. So go visit the FINO team.
Please visit the FINO team.
Cool. Thanks for that. That was a great breakdown. I feel like, I don't know, I see those questions all the time on Instagram, and people are just confused. So hopefully you have a wonderful nurse like Wendi. So, all right. So that was Wendy's last question. This is Dr. Huber's last question. So enjoy this one. This is kind of a confusing one for patients. So let's see it. So why does my trigger shot have to be exactly 36 hours prior to egg retrieval? What even is a trigger shot? How does it work? Enlighten us, Dr. Huber.
Will do. So I'll start by saying that there are, in general, two different classifications of trigger shots, right? So one of them is the HCG, or human chorionic gonadotropin trigger shot, and then the other is a leuprolide acetate trigger shot. Why we use one over the other really depends on the type of cycle that we're doing. Some cycles you can't use a leuprolide acetate trigger, some you can. The goal of the trigger, though, is to initiate the process of egg maturation, right? So when you're born with all of your eggs. You're a millionaire. You have 1 million eggs in your ovaries. As you age, and once you get into puberty, those eggs reinitiate their maturation process and then get frozen in a certain portion. During the IVF cycle, that follicle stimulating hormone has made those eggs, or the follicles that surround those eggs, I liken the follicles to the apartment that the egg grows up in. And the egg, what it needs is that trigger shot to start that maturation process over again. Only mature eggs can be fertilized. So we give the trigger shot and then wait 36 hours to take those eggs out of the ovary to make sure that those eggs have enough time to become mature. If we went and did the retrieval 12 hours after the trigger shot, we would get all immature eggs, or what we call M1s, right? GV or M1s, and those cannot be fertilized. Waiting closer to that 36-hour mark is where we have a higher chance of having mature eggs that we can actually utilize to fertilize and then increase our chances of getting embryos. Remember, Mother Nature takes her cut at every step of the way. So if we get 20 eggs, 15 of them will be mature, 10 of them, 12 of them will fertilize, only 6 of them will make it to day 3, only 4 of them will make it to day 5. So at each step of the way, we're trying to increase our chances of getting high quality embryos. The two different trigger shots, won't go too much into the reason why we have those two shots, but in general, they mimic what the brain will tell the ovary before you're ready to ovulate. Now, exactly on 36 hours, I typically say you have about a half hour to 1 hour on each side of the fence, right? If we did the retrieval at 35 hours or 37 hours, we're really close to that's our optimal egg maturation window there. So that's why we do the 36-hour window.
It's just so exact. Yeah, the trigger shot is very important.
Yeah.
Yeah, and that timing, that associated timing is absolutely critical. So cool. Thanks for breaking that down. That makes a lot of sense. All right, this is our very last question, and it is for Vicky. So Vicky, what are some common side effects for fertility medications that I should look out for, and why do they take place?
So the most common side effects are going to be very similar to what you feel during your period or during PMS. So it's bloating, breast tenderness, headaches. So it's just going to be very similar to that. Mood swings. You know, patients are already stressed, and then on top of that, they get that boost of hormones. It could be a little bit more, you know, pronounced because they're taking more hormones than their body would naturally produce during prior to their period or during. So those are the most common side effects. Why they happen is very simple, because you're basically taking the hormones that your body produces. Those are the same hormones, but you're taking them exogenously. So again, it produces the same effects as if you were to get your period prior to your period or during your period. And of course, the symptoms to watch out for, you know, for hyperstimulation is something that is very severe. You know, Dr. Huber spoke about that. So those are really there's really nothing outstanding other than that. If a patient's feeling some kind of, you know, an allergic reaction, obviously, so they need to call right away. But that's not the injection site reaction, we're talking about an allergic reaction. So itching, pretty, and they're all over their body, or they're starting to having systemic effects, like, which I've never, ever had a patient experience, but we always warn patients about an allergic reaction to any new drug that they're taking.
Totally.
So
Awesome.
that's about it.
Cool. So it's just like a period, you guys.
Yeah.
So yeah, don't call Dr. Huber at 3 a.m. if you're having what seems
period-like
like
symptoms.
period cramps.
Yeah. Period cramps. Yeah, cramping is another one.
And I welcome all phone calls.
Call Vicky. How about that?
Yeah, absolutely. We are definitely also available. We can answer this. So
You can always call me too. Okay, that was 9 questions, 3 questions each for these 3 fabulous and wonderful contributors to the fertility industry. So I would love to thank each of you so much for doing this. This was a ton of fun. And thank you, Fertility Rally, for hosting us on your platform. And we hope that this was helpful to the Fertility Rally community. So happy holidays, everybody. And we'll see you soon.
Thank you, Abby.
Thank you.
Thanks, you guys.
Take care. Best of luck. Happy holidays.
Bye.